Hi, everyone. Excuse me very much. Good morning, good afternoon, everyone. My name is Sarah Ford, and I'm the chair of Core Group's Board of Directors. And I'm delighted to welcome you today to the Marketplace on Child Health. We have a fantastic series of presentations lined up for you. And as you know, the Marketplace is one of the most interactive and engaging sessions in the conference, where our panelists will be presenting ideas and projects and efforts they've been working on to improve child and adolescent health all over the world. We encourage you to actively participate with our panelists by using the chat, where you can put your comments, your suggestions, your questions, and I'll help moderate that to make sure that our presenters and our panelists see what's there. So we have a great lineup today. We'll be starting with, excuse me, Grace Peters from Smile Train and Camila Osario from the Fundación Clínica Noel, who will kick us off today, followed by Clodagh McLaughlin from World Vision Ireland and Joseph Musa from World Vision Sierra Leone. And last but not least, we have a great presentation from a large group of panelists: Marie-Noëlle Brunet-Dries from the World Health Organization, Ana Gunz from Western University, Fernando Diaz-Barrega, WHO PAHO Children's Environmental Health and Health Risk Assessment Center, Alexander Doroshenko from the University of Alberta and the Alberta Health Services, and Amalia Laborde from the Republic University of Montevideo and the University Clinical Hospital. So with a reminder for you to put your questions and comments in the chat, I'll hand it over to Grace and Camila for their session, 9 Reasons to Smile, At Home Psychosocial Support for Cleft Lip and/or Palate for Families Around the World. Over to you, Grace and Camila. Thank you very much.
Hi, everyone. Sorry, I'm just getting this set up. Is it in presentation mode? Oh, there we are. Can you guys see the presentation?
Yes, I can see it, Grace.
Yeah, we can see it fine.
Great. Hi, everyone. Welcome to our Marketplace presentation, 9 Reasons to Smile at Home Psychosocial Support of Cleft Lip and Palate Families Around the World. My name is Grace Peters, and I work at Smile Train to expand our comprehensive cleft care programs. For those of you who are not familiar with us, Smile Train is the world's largest cleft lip and palate nonprofit. We partner directly with local hospitals to strengthen health systems and empower local medical professionals to provide comprehensive cleft care to individuals in their own communities. I was born with a cleft lip and palate in the United States, and my family and I have been supporting Smile Train for most of my life, so working here is very special to me. And while Smile Train supports safe and quality cleft surgeries for individuals around the world, we know that cleft care doesn't begin or end with surgical care. So we focus on providing access to comprehensive services, including nutrition, speech therapy, orthodontics, oral health care, and psychosocial support. And here in this next slide, you'll see just a picture of showing that Smile Train has partners all around the world. And one of our strongest partners is in Colombia, Fundación Clínica Noel. And so now I'll pass it over to Camila Osorio, a psychologist and friend from one of Smile Train's strongest comprehensive cleft care partners based in Medellin, Colombia.
Hi, Grace, thank you. Hi, everyone. My name is Camila Osorio. I'm a psychologist. I was born in Medellin, Colombia, but I lived most of my life in the United States. But I'm currently back in Colombia working at Clínica Noel, and I have been there along with Smile Train for about 2 years now. Clínica Noel has been serving families and impacted by cleft lip, and palate well over 100 years, and their entire medical team has a tremendous experience with holistic and supportive and comprehensive care with all the families and patients.
So our marketplace idea that we want to share with you is Smile Train's 9 Reasons to Smile Family Fun Activity Booklet. We want you to know this important resource and even understand how you can apply it and understand it in your own areas of expertise. At the onset of COVID-19, with in-person cleft treatment postponed around the globe, Camila and we came together and we developed this booklet, which includes art projects and on self-esteem, as well as engaging art activities and games that help children explore their emotions, their relationships, and help build their self-confidence. While the booklet continues Smile Train's psychosocial support programs, it is also aimed at addressing the challenges that patients have faced due to the postponement of in-person care. One question that I get asked a lot is why it specifies 9 reasons to smile. And fortunately, there's a simple answer there, which is that the title came after the booklet was made, and there are 9 different activities in the booklet.
So Grace, how about we do an activity with everybody?
That sounds like a great idea, Camila.
All right, so we're gonna, go ahead.
Now you can go.
All right, so today we're gonna do the activity Attitude for Gratitude. Everybody that wants to participate that's with us today, we are going to need paper and pen. If you don't have these materials, it's okay. We invite you just, to think it and to have it in your head. And later on, we can share the ideas if you want.
Camila, do you know what the word gratitude means?
Of course, it means being thankful or grateful with everybody and sharing this with your whole family or everybody around you. Now, we invite you to fill this template. The invitation is to be grateful or give, be grateful for someone in your life. So you're supposed to fill the, give like a little thank you note saying why you're grateful for them and what you appreciate with them or for them.
And showing your gratitude not only makes you feel good, but it will make the person that you're grateful for feel really special.
Yes, the idea is that you do this activity with us right now. We know we have only a few minutes. So if you want later on, we can share everybody that wants to share their thoughts, their experience about the activity, and we can reflect on it later on.
All right, so moving on. Our long-term goal is that children know how to use this booklet as an introduction to art or reinforcement to using art to discover and grow their confidence, inner strength, and health, not just when times are fun, but also when times are challenging. Camila, why is that so important, especially for children and families affected by cleft?
Of course, children affected by cleft lip or palate experience many psychosocial challenges. They often overshadow by the physical effects that we can see. But to ensure that every child and adolescent, fulfill their goals and achieve their full potential, it's essential to have a psychosocial care. According to UNICEF, children who understand that they are valued and important tend to achieve this goal at a higher rate. They get support from their families and friends and community that understands what they're going through.
And self-confidence promotes coping skills, solution finding, and full potential, and helps the child reach their full potential regardless of their situation. And Smile Train and Clinica Noel are dedicated to seeing that every child born with a cleft lip can reach their full potential, and that every family feels supported during that journey. So 9 Reasons to Smile was first launched in English, French, and Spanish in parallel with the WHO Walk the Talk virtual event in May 2020. To further increase awareness of psychosocial health, Smile Train hosted a virtual celebration of 9 Reasons to Smile, which is the photo on your left, and alongside regional celebrations that were hosted in Brazil and Mexico. The booklet is now available in more than 15 languages, and it's shared worldwide throughout Smile Train's website and WhatsApp messaging. The global virtual celebration now has over 4,000 views on Facebook and YouTube, and we continue to receive photos and stories from families and partners around the world sharing how the booklet has impacted their happiness and their overall mental health. And this booklet is tied to a larger initiative called Art Impact for Health with the WHO that encourages people and communities everywhere to leverage art as a way to access health for all.
I wanted to share with everybody just a short story and experience about a family that did, the activity as a family with the booklet. Her name is Luciana. She lives with both her parents, and I want to share her perspective and then her parents' perspective. So from for her perspective, she was working on the booklet, and she said that it helped her reflect on her family's value, the importance to always communicate with them, and her personal qualities and what makes her unique. From her parents' perspective, they said that they felt very proud to see her journey, her strengths, and they felt very, very thankful for Clínica Noel and Smile Train for being there and supporting all their journeys. So this is another way to make us reflect that, these booklets, this interaction that we do with them helps them, patient, family, and everybody to feel strength as a whole family.
And these are actually photos that Camila took when working with the 9 Reasons to Smile booklet with her patients at Clínica Noel.
There's an urgent need to increase emphasis on child and adolescent psychosocial health with global care, which has become more evident during COVID. When we did this booklet, we saw that we needed to reach out, not just in Colombia, and we needed to reach out worldwide to help them to promote this psychosocial care.
And now we just have a few photos that we wanted to show you guys from around the world. This is photos from Brazil and the Philippines and Nigeria and Mexico. This was an online 9 Reasons to Smile session that happened in Mexico and Indonesia. And so through our commitment to raising awareness on the importance of psychosocial health and the importance of art and expression as a way to find full healing and health, Smile Train has built innovative methods to support cleft patients' mental health and well-being worldwide. So now we'll go on to the questions.
If anybody wants to share their activity with us, what they felt going through it, what they felt doing this activity, taking a minute to think about what you're grateful for or who you're grateful for, feel free to share with us.
It's a lovely invitation, Camila. Thank you very much. I've been staying with my sister, and I was thinking about how grateful I am for her to be with her during this pandemic. So thank you for that exercise. I appreciated the overview, and I wondered if the two of you might have some examples of how the 9 Reasons to Smile activities have perhaps been, whether they've been integrated into projects that are more community-based projects that help families that have children with cleft lip and palate, as well as children who do not, or in other types of projects as well.
Well, I wanted to add something really quick. This is intended for cleft lip and palate, but it's meant as a family to do it. So another short story was, we have a patient at Clínica Noel, and he has 4 brothers and sisters. So this is an activity that benefits everyone in the family. So it's not just meant for him, it's meant for his brothers and sisters to do along, and to find their strengths and their qualities and their self-esteem, to build on that and to help the family communicate and find ways to become stronger. So this is intended for everybody also.
Yeah, and here's just a few of the activities. So you can see there's word searches, and there's this letter, there's writing down, I am beautiful, or I am hardworking, and putting it in a cup. And then whenever you feel down, you take that little thing, your stick out of the cup, and it just makes you feel good about yourself. And so these are all, like Camila said, it's designed by Smile Train for cleft lip and palate patients, because there is a need for psychosocial support with our children who are born with clefts. But it can really be used for anyone, and the whole family, which is really special. We haven't done anything yet with larger organizations with this booklet, but it's just the start, and so we're really excited. We're hoping this is our first edition, so maybe we'll come out with another edition this year. Does anyone else have any questions or want to share their attitude of gratitude?
You mentioned, the two of you described that you started in English, French, and Spanish, and that it's now available in 15 languages, excuse me. And the link to the guide is in the chat. Can you talk a little bit more about how people are using it? I noticed you had Mexico did it virtually. Could you tell us a little bit more about Mexico's experience in using it virtually?
Well, I mean, so Mexico had their own, I was actually referring to the celebration. So it was more of like an awareness celebration that Mexico and Brazil had. As you can see in this photo right here, Camila and Pam Sharon and I, we hosted a virtual celebration in July just to promote awareness of the booklet and to really celebrate just the importance of family and art and you know, raising awareness for psychosocial health. And so Brazil and Mexico wanted to do something similar. So that's what they did. They kind of did that in parallel with our virtual global celebration.
And I can tell you a little bit about how we do it too online. I mean, with this booklet, the intention is to get everywhere. So within Colombia, we told the parents, we gave them the booklet, they can download it, or if they could make it to the clinica, you know, get it physical. And we said, we're going to do this activity. We name it. This is the materials you're going to need. And then we connect all through Zoom and then do the activity together to share. You know, we wanted to give them the feeling that we're still together. We're still connected, that, you know, the pandemic has us, you know, in our house, but we're still, you know, there for their support. So we do it online, but we're doing the same activity with the same materials, sharing our experience through Zoom. So that's a way we can still connect to them and share this piece of material we did. That was our experience at Clínica Noy.
That's fantastic. Thank you so much. And really thank both of you for your great presentation.
Thank you all.
Sorry, really appreciate it. And I'll keep monitoring the chat in case questions or expressions of gratitude come out again. Thank you for introducing us to this tool.
Thank you.
Thank you.
Thank you both. So thanks, everyone. I'd like to welcome our second presentation. This is 3 models for improving MNCH access and outcomes in African countries. We have Clodagh McLaughlin from from World Vision Ireland, and Joseph Musa from World Vision Sierra Leone. Clodagh and Joseph, thank you so much. We look forward to your presentation.
Thank you, Sarah, and hello, everyone. I'm just going to share my screen, sorry. So I hope you should be, oh, excuse me, gone a bit too far. Sorry about this. Now, hopefully. So, can you now see?
I can see it now. Thank you.
Okay, thank you. Yes, so my name is Clodagh McLaughlin and I'm Senior Programs Officer with World Vision Ireland. And I'm joined by my colleague Joseph Musa, who is the project manager for our AIM Health Plus program in Sierra Leone. So we'll be discussing AIM Health Plus and the 3 models utilised within the program to address and improve MNCH access and outcomes. So AIM Health Plus is a 5-year program funded by Irish Aid and has been extended to into its 6th year next year to 2022. It's being implemented in 4 countries in Africa. So in Mauritania, in Yassaba and Brakna regions, in Bont district in Sierra Leone, in Bahi and Chimba districts in the Dodoma region of Tanzania and in Busia district in Uganda. The program goal is to reduce neonatal and under 5 child mortality by 20% and maternal mortality by 15% in the program sites by the end of the program. And we have 5 objectives to help us achieve this. Children and their mothers are well nourished. Children are protected from illness and managed appropriately when ill. Children and their caregivers access and utilize essential MNCH services. Health governance and partnerships are strengthened at micro, meso, and macro levels, and that MNCH outcomes are accelerated and amplified through the use of digital technologies. So AIM Health Plus employs 3 of World Vision's core project models to bring around a 360-degree support for behaviour change related to maternal, newborn and child health practices at individual, household, community and environmental levels. So at an individual and household level, the programme uses TTC, which is timed and targeted counselling. So this is a family inclusive behaviour change communication approach targeting families of young children. It encompasses a wide range of life-saving health practices through appropriately timed messages which are delivered using interactive storytelling. So it applies a dialogue counselling methodology based on the assessment of current needs and practices and negotiation of progressive improvements with households. And TTC actually engages both parents and decision makers, embracing a family inclusive and gender transformative model of child health and development. And it can be delivered by a range of cadres, but within the AIM Health programme, it is delivered by community health workers. And so at the community level, we have COMs, which are known as, which are community health committees. And the COM model focuses on 2 types of representative health groups. So these are community health committees or health facility management committees. And these groups are often already established and backed by the Ministry of Health, but in some cases they can be weak and poorly supported. So COM programming aims to strengthen the capacity of these groups to identify and respond to important health issues in their area, contributing to overall community health system strengthening, capacity building, and improved overall health outcomes. And then at an environmental level, we have CVA, Citizen Voice and Action. So this is a social accountability and local level advocacy methodology that addresses inadequate essential services by improving the relationship between communities and government and empower communities to hold the government to account. So it facilitates the transformation of relationships between citizens, government, so civil servants or elected officials, and service providers like doctors, teachers, nurses, so that everyone in the community can actually work together towards the well-being of children. So these are the 3 core models used in AIM Health Plus, but taking learnings from the earlier phase of the programme. It's also integrated with health facility strengthening through capacity building, infrastructure support and equipment, but also intensification of WASH and nutrition interventions through support groups such as care groups, mother support groups, or grandmother groups as well. So the models actually complement and build on each other. So the COMs support CHWs, helping to build strong links and relationships between the community health workers and the health facilities on one hand, and also between the community health workers and the communities they serve on the other hand. So the COM model actually supports TTC by addressing barriers to positive health practices that CHWs might be unable to address in the home. For example, COMs will carry out root cause analysis of health issues in their communities. And these root causes might be related to harmful social or cultural or gender norms, and then they'll seek to address these through engaging with faith communities or other community gatekeepers, or through other models that are more effective in shifting norms. Or root causes might be at a health facility due to limited capacity, equipment or infrastructure, or due to attitudes of health workers, or even environmental root causes such as unhygienic community spaces. So the COMs identify prioritize health issues through data collected by CHWs from their household visits, or through their root cause analysis, or through health facilities assessments. And they add these prioritized health issues to CVA advocacy agenda and actually engage health service providers around these issues, thereby bringing about a transformed relationship between the service providers and the communities and their catchment areas. So this has led to a number of improvements, such as reduced absenteeism of health workers, improved levels of respectable maternal care being delivered, and increased satisfaction amongst mothers and pregnant women in receiving health services. So you can take, for example, just the photos on the left here are from Bulumbi Health Facility in Busia district in Uganda. So the first photo just shows the health facility prior to its refurbishment, but the poor infrastructure of the facility and the staff housing that goes with it resulted in health workers not wanting to work or stay there, and reduced capacity to actually deliver the care it should be able to provide to the community, impacting on skilled birth attendants and outpatient services. So based on the health facility assessment, community complaints received by the comms, and I suppose health outcomes themselves as well. The comms and CVA worked together to put in place a plan of action to renovate the staff houses and the health facility itself, and to actually increase the number of healthcare workers working there. So the CVA group wrote a letter and actually met with the Chief Administrator's Officer, explaining the situation and the impact that it's having on community health, which resulted in a commitment by the Chief Administrator's Officer to actually financially support the refurbishment of the health facility and of the housing for the health workers. So in addition to this, the CVA also worked with a local fundraising association to raise more funds, and once all the funds were raised, they were able to rehabilitate the health facility, the housing for this health workers, and later then to actually have an additional 3 health workers deployed to the health facility. And as a result, the health facility has seen an increase in the number of deliveries, averaging from 30 to 80 on a monthly basis. So it's just I suppose a small example just to show how taken together the 3 models actually work to support the overall strengthening of the community health system and in CH house or outcomes. So I'm just going to pass over to my colleague Joseph now to provide an overview of AIM Health Plus in Sierra Leone.
Okay, thank you very much, Clodagh, for taking us through the first part of the this presentation. I'm Joseph Musa, the AIM Health Project Manager from Sierra Leone. I've managed AIM from the onset, that was from 2012 to 2016, and I'm managing it again from 2017 to 2021, and has been extended to December 2022. Sierra Leone is among one of those countries with high infant mortalities, and we can see from the results above, from 2013 to 2019 demographic health survey, it used to be 1,165 maternal deaths per 100,000 births. That was from 2013 to 2016, 17. But then the recent survey conducted through the demographic health survey, it has been reduced to 717 in the last demographic health survey that was conducted in Sierra Leone. And then we can also see a reduction and improved in the infant mortality, has been improved from 117 per 1,000 live births from 2013 to 2016, 2017. From the recent survey that was done, it has reduced down to 75 per 1,000 live births. In Born District, we operate in 2 chiefdoms. Basically, we are in the island, which comprises of the Bond municipality, and then we have the Dema, and then the City Chiefdom, and then Imperi. So basically, we are operating in 4 chiefdoms in Bond district. And we are implementing all the core project models that the health project is implementing in World Vision. That is the TTC, which directly deals with the community health workers. And then we work with the facility management committees, which we called the COMS. And then we also worked with citizens and voice of action working groups. These are groups that hold the duty bearers and the government accountable for what they said they will do. But let me go back to the TTC CHWs, the impact that we have created in the communities. The CHWs actually do conduct the TTC project models, and that is the changing behavior in household level to increase demand for health services. Now, maybe let me share with you an example that we have had a remarkable impacts in the community and even as well as World Vision. In Bond District, when we compare the mortality rate that occurred in the first parts of 2019 with the proximal districts like Bo and Pujehun, it was observed that Bond District has the lowest maternal deaths when compared to the other district. This was an attribution or a contribution of the CHWs implementing the TTC program. The other impact that we have created using the TTC through the CHWs is that we have had 2 outbreaks in Sierra Leone. One was Ebola in 2014 to 2017. And there was a myth surrounding Ebola because we are implementing in communities that are having high illiterate level. So myths of any kind do spread like wildfire. So the myth behind Ebola was that Ebola was transmitted by health workers. So actually mothers, pregnant women and more, and the population had a reverse thought about seeking health service from the PHU. So there was a downtrend in utilization of health services at PHU level. So what we did was that we had to call the CHWs, and they do the behavior change communication at household level. So this actually contributed to the increased utilization of health services at PHUs across the areas we are implementing, and even across Bond District as well. And then World Vision in general in Sierra Leone has adopted the TTC program. So in the months of February, March last year, I actually went around all the areas where World Vision is implementing to train the community, the development facilitators and the CHWs in those areas so that they will adopt the TTC program models that can be used in their various areas. And you know, TTC alone cannot work. So we are working together with other community structures like the COMS. The COMS are literally referred to here as the facility management committees. So one of the impacts for sustainability, the COMS actually felt that there was a need for us to ferry pregnant women, lactating mothers for community growth monitoring and immunization. So what they did was that they did an assessment, and then they requested World Vision to make a boat for them. So a boat was provided, and they are now using this boat to provide emergency services in the island, and they are also using it to ferry women for services like ANC, PNC, growth monitoring, and immunization. And then we also train them for sustainability. We train them on savings for transformation groups. So they are using the social fund. That is the fund that is contributed voluntarily by all the members in the COMS group. And they are now using this social fund to support most vulnerable families. For example, in providing school uniforms, school bags, and even supporting the families also if there are any emergencies so that later on they can refund those monies that are used in this social fund for those communities that are very far off from the PHUs. But they are also working closely with Channels of Hope for Faith Leaders. We have done Channels of Hope for MNCH, and the COMs are working closely with those faith leaders, and they are also now going to disseminate information in all the PHUs on the essence of exclusive breastfeeding, the essence of bringing children to the PHUs. The CVA, as Claude have said, it's a social accountability structure that holds all levels of leadership accountable for what they said they will offer the communities at a policy level. So with the CVA, we do what we call standard measures, and we do what we call scorecards. So those tools are used to improve services and influence policies. So we have seen that this one has created a very big impact in our operational areas, and nearly 90% of our PHUs, because of the advocacy, the lobby that the CVA groups are doing, they now have at least 3 staff, or some are even having above 5 staff in each PHU. So you can also, because of integrating all of these core project models, you can see some of the promising results that we got in our midterm results that was done in 2018. In Imperi, there was a reduction of 3% of child neonatal mortality, and then in Imperi, 8.2%, and then in Shabro Island, 3%. You can see the under 5 reduction in the under 5 mortality also, 11.5% in Shabro Island. And then you can see.
Joseph, I'm so very sorry. This slide is fantastic, and we'll leave it up. Perhaps, Claudia, you can leave it up for a minute or so. We're getting tight on time, and I want to make sure that our last group has a chance to present. So I really want to thank you, Claudia and Joseph, for an excellent overview of the AIM project. And please feel free to put in the chat if there's any questions or additional things you'd like to add for the group. But I thank you both very much, and I'm going to go ahead and introduce our third panel, which is on child health and the environment, recognizing, managing, and preventing environmental illness in our communities. I'd like to introduce the moderator for this panel, and she will then introduce the panelists. So allow me to introduce Marie-Noëlle Brunet-Dries from the World Health Organization. Over to you, Marie-Noëlle.
Thank you very much, Sarah. It is really a pleasure for WHO to be here today. We have a whole variety of panelists that are working on children's environmental health and are also part of WHO collaborating centers, which are centers of specific expertise that provide the collaboration for WHO to be able to carry out their activities. So today we'll be talking with all the participants about child health and the environment, how to recognize, manage, and prevent environmental illnesses in our communities. So I'll be introducing each panelist as we ask them for reflections. I'll be giving a very brief overview just so everyone knows how this will flow. And then Dr. Anna Gunz will present a case study, and then we will hear from our 4 distinguished speakers and participants today. And then, of course, we'll be taking questions from the audience, so it would be really helpful if people can start putting questions all along as we go. So just to start, so I'm Marie-Noëlle Brunet-Dries, and I work in WHO in the Department of Environment, Climate and Health. I work specifically on children's environmental health and how to create environmental strategies and environmental actions that can actually decrease the number of diseases related to the environment in children. So this is a number that WHO published about 3 years ago, and we know today that 1 in 4 children under 5 in the world die because of causes that are entirely preventable and related to unhealthy environments. The same is true not only for deaths, but also for diseases. We know that 26% of the burden of disease could be reduced if we address some environmental key factors in the world. We also know more and more about the importance of the early life period, of what happens in the womb, of what happens in the first few years of life, where our different organs are developing. Child development continues depending on the different organs. It can continue about 20 years of age for some organs like the lungs or the brain. But we know that during this time, when we have an environmental factor affecting a child, the impact can last a lifetime, and children have a very long life to live. So just to give you an idea, when we talk about environment, Albert Einstein used to say the environment is everything except me. So there's a whole variety of factors. We talk mostly about water quality, access to water, sanitation, hygiene, also chemicals, also heavy metals like lead and mercury that are actually highly neurotoxic, and also other kinds of chemicals, climate change, air pollution. We'll be hearing about a little bit more about those two today in the session. Also hazardous waste. We have new emerging issues like electronic waste that is only 20% of it is, less than 20% of it is recycled, and the rest is torn apart many times by children in the poorest parts of the world. So just to focus a little bit more on air pollution, on one of these key factors, we know that we had a publication 2 years ago showing that 9 children out of 10 in the world are exposed to air pollution levels that are above WHO guidelines. So this is very unhealthy for them. And though this happens a lot in low and middle income countries, we know that this is a reality in every country in the world. And we know how this megacity is completely covered in smog. So when we talk about air pollution, the main sources are here in traffic. So they come from industry, they come a lot from transport. They come also from household air pollution, from household energy, from the way we heat and we cook in our homes. There's many other sources. Another important source is, of course, the agricultural practices, burning of agricultural waste. Another issue that is just the other side of the coin of ambient air pollution is household air pollution. So when we use unclean fuels and technologies to heat our houses, to cook in our houses, to light our houses, things like kerosene, like carbon, sometimes vegetable waste, wood, charcoal. I mean, all of these are very bad for our health, and especially for children's health. This is a reality that many people live with. They have rooms that are so smoky that they can barely see. It's also a reality of people who cannot change the way they live, and this is the only way that they can afford to heat or light their homes. So this is why it's so important that we actually provide the solutions and not only raise awareness about this. So these are some of the organs in a child that are affected by air pollution. We have this in our recent report. So it affects, of course, the respiratory system, the brain. We know it is stunting neurodevelopment. It also gives way to adverse birth outcomes, to childhood cancers or cancers later on in life, and also to cardiovascular diseases later on in life. We know that every year there's about 600,000 children that die, young children that die because of air pollution. So this is my final slide, and so this is to show that we all the different sectors need to act for us to be able to address this issue and to protect children's health. So the way that we heat our homes, what we can do in the clinic, municipalities. We often say that mayors are the new ministries of health in WHO, because the actions and the policies that they decide can really have an impact on the health of the people, the governments, the communities, the schools themselves. So we all have a part to play, and I think we'll be hearing about this a little bit more from our panelists now. So thank you so much. This is our website in WHO, and particularly thank you also for this session. I should have said this at the beginning, our collaborating center in Canada and Dr. Leslie Brennan, who organized this session. So now we'll start with a case study with Dr. Anna Goons. Let me quickly introduce her. I'll put back the presentation on. So Dr. Anna Goons is a pediatric intensive care doctor at Children's Hospital in London Health Sciences Centre and assistant professor at School of Medicine and Dentistry in Western University, Canada. For medicine, she did a degree in geography as well, and she has had numerous roles within the Children's Hospital and Western University. She's currently the director of neonatal pediatric transport team and associate program director of the pediatric residency program. Dr. Bruns is currently working to better understand the effects of climate change on child health, as well as to improve healthcare facilities' understanding of necessary mitigation and adaptation exposures. Anna, the floor is to you now. Thank you.
Thank you very much. So I'm going to present a case just for a few minutes now that will be the basis for the rest of the panelists to have a discussion from their point of view. This is obviously not a real case, but it is in literal sense, but this is a case that we see multiple times in many different countries year in and year out. So I'm going to talk about Safia. Safia is a 7-year-old girl who is otherwise healthy, other than the fact that she has a history of chronic asthma. And unfortunately, in the last few years, although she's been trying hard with her mother to manage her asthma, and she's very good at taking her medications and puffers, they've had to go to the local clinic multiple times with episodes where she's had really severe problems with her breathing, including a number of hospital admissions, including an ICU admission. So she's being sent to a pediatrician to look into this further. Just to give you a bit more information about her, where she lives. So whenever we're talking about breathing problems, we always want to know a little more about the environment which the patient lives, because those are common triggers. So Safia lives with her mom and her little brother in an apartment building. It's a high-rise, and there are multiple other high-rises in the area that they're in. Inside the home, there are no smokers. They do have a cat who loves her Safia very much and always sleeps on her bed. And they have cement floors with a few rugs over them. And her mom keeps her house as clean as she can because she doesn't certainly worries about the Safia's breathing. Outside her home, there's very little green space where they live. There isn't a lot of trees along the road. There is an area of grass around the building that she lives with, a small playground where her and other children play. Fortunately, it's right along the road, which is a major commuting area for the city in which she lives. She walks to school with her mom every day, which is about 1 kilometer away. And part of the problem this year with COVID is that they found that when she gets to school, she often has a cough. And so she's been sent home multiple times because they're worried about her cough when they were doing in-school learning in her area. In the area which she lives in an industrialized country which has fairly good regulation for emission standards, both for individual motor vehicles as well as industry. However, in the area where she is, there are lots of cars, there's lots of traffic, and there isn't a lot of people who take public transit when it's available to them. And their area is downwind about 10 kilometers from a larger industrial complex. So that is the patient that they have in front of them. And when the doctor reviewed all of her medication, she's on reasonable treatment. Her mother's extremely compliant, and Safia is very good at taking all her puffers. And at the end of the day, her mom is a bit stuck, or the pediatrician feels a bit stuck because she feels like a lot of the air quality around where Safia lives is actually part of the problem. And so this is where this physician is at. And I'm going to ask now, the different panelists are going to come through and give different perspectives on how they might address this.
Thank you very much. So this is Fernando. So Fernando, for the sake of time, I invite you to introduce yourself very quickly. You can now react to this case study.
Well, my name is Fernando. I'm from Mexico. I'm working as the director of the Collaborating Center on Children Environmental Health. And can you give me the next slide, Marie-Noël?
Yes, of course.
Well, we're working in a concept, a new concept. We call it contaminated communities. Communities where children are simultaneously exposed to chemical, physical, biological, but as well social threats. The next one, please. And I'm going to give you a couple of examples. The first one is community where located in an area with artisanal mercury mining. And again, I'm going to say very clearly, this is mercury mining, not gold mining using mercury. This is mercury mining. So in this area, children are exposed to mercury and arsenic, and you can also find child labor. The next slide, please. The second example is in a very different setting. This is an urban setting. with the brick kilns where different wastes are being burned, including electronic waste. And again, you find child labor, and then again, you find children heavily exposed to chemicals. The next slide, please. So these are examples with in this new concept of contaminated communities. And if you want to do intervention in this kind of communities, yes, you need to do environmental interventions. Yes, you need to do health interventions, but also you have to look for the development of the whole community. So I leave you with this message. You need to work in an integrated team with different kind of ideas and different type of methodologies. The next one.
Thank you very much, Fernando. Our next reaction is going to be from Professor Amalia Laborde, Dr. Amalia Laborde from Uruguay, Montevideo. So Amalia, in order to be more quickly, I'll let you also introduce yourself, please.
Thank you, Maria Noel. Hi, everybody. I'd like to do a general comment and a comment about the case, trying to do it in 2 minutes. I'd like to highlight the key roles of health professionals for promoting health environment, for preventing environmental disease, but maybe most important, for helping children to reach their maximum development potential. As it was mentioned by Maria Noel, there are key roles of health professionals that we need to have involved in this issue. One is being informed about the environmental risks that may affect their communities and their patients. And the other is to recognize sources and scenarios of exposure, like Fernando show us, because they are the essential first steps to involve health professionals with the necessary solutions. There are several tools I'm showing in this slide, but there are more publications and training materials aimed at capturing the attention of the health professionals and the health sector in general, and of course building health professional capacities to deal with environmental threats to children's health. Let me mention the WHO Children Environmental Health Training Package for the health sector that includes modules on ambient air pollution, indoor household air pollution, and also the package has modules focused on the disease, for instance, the childhood respiratory disease linked to the environment. One of the most integrative modules, and maybe we can see the other slide, is the one that describes the pediatric environmental history, or well known as the Green Page. This module that was updated recently by colleagues from Alberta, Canada, has or better guide the essential questions we need to think about in order to recognize exposures, and at the same time gives inspiration for locally prepared sets of questions according to the environmental problems we identify around our communities and patients. And maybe in many countries, there is not exactly a green page, but just a green checkbox or a green panel to incorporate in the clinical history. well, just for instance, in air pollution, we need to do some questions about the energy the families use, about the fuels and so on. So and finally, I'd like to mention also that this pediatric environmental history is not just a tool for the clinics. It's or for face a disease. It's a tool to very useful at the well child visit, at the routine children checkups, when they are in the best place, in a unique place to prevent children exposures, and also give very important information for surveillance and decisions to protect the community. So these are my thoughts. Thank you very much.
Thank you very much, Amalia. We next have Dr. Alexander Doroshenko. So Alex, I'll let you introduce yourself and give us some feedback.
Good morning. So we have a very little time left. I work in the pediatric environmental health clinic in Edmonton, Alberta. So, and I just wanted to add a couple of comments to what already been said, particularly in relation to collaborative efforts to manage environmental health exposures among children. So now one of the points that I would like to make is how the role of clinicians, pediatricians, and public health professionals actually overlap there. So I work in pediatric clinic, but I also medical officer of health. I work closely with the public health colleagues. And on this slide, I just showed you how clinical management is often, or clinical assessment can actually lead to public health interventions. And I just showed you on this slides that when patients present, they usually present with environmental health concerns, and in clinic we conduct environmental health history, that what just been talked about. So we determine whether the exposure is actually capable cause clinical presentations, or sometimes patients present with just the exposure concern. They may not have any clinical presentation. So we obviously in the clinic do the physical exam, we perform laboratory testing if we deem necessary. So we usually test biological specimens. So for either chemicals themselves, if there is exposure, or the effect of those chemicals on the functions, and we recommend some treatment and educate families. But often in the clinic, what happens is that we have to reach out to public health, and when we reach out to public health, particularly to reduce the exposure, even in individual homes, but also at the population levels. Whether it is due to contaminated soil or exposure inside of the house or exposure in schools. So the public health professionals in Canada can do environmental test sampling, so they do public health inspections, so which help clinicians to decide whether exposure was really significant or not. So they also conduct these public health inspections and putting in compliance with the law and regulations. So they often organize field epidemiology work and participate in health promotion activity at the population level. I think that's my point here, is that how important it is interact between clinicians and public health professionals to manage environmental health concerns in children. Thank you.
Thank you very much, Alex. So Anna, just for some final thoughts before we ask questions. Thank you.
I'll give you 30 seconds, which is, at the end of the day, even coming back to that, from that one girl, you can see that there's so many different things that actually affect her health that are outside the realm of a clinician. And one of the things that is happening in the world, as we're all probably aware, is climate change, which is only going to make things worse. In urban areas, it's going to make heat worse, it's going to increase secondary pollution, and as well as the contribution of different types of burning and fires and combustion, such as the large parcel fires that are happening. And, you know, as individuals, there's things that we can do, but at the end of the day, the solutions are outside of health, they're outside of public health, And so I think it really is a calling, especially to industrialized countries, to increase your political action, for physicians to step up and to use their voice, as well as nurses and healthcare providers and public health, to learn how health impacts, how it is affecting people, to educate those around us, and to really talk to your government, whoever your government representatives are, to increase global action. And I think that is ultimately what we need at every level of environmental health, but all of these crises are just being exacerbated by climate change. So that, I think, is how I would tie it together. Thank you.
Thank you very much. I think our time is up. So I hope we were able to show today that environmental health and environmental risks are not only a concern, they're also a children's rights, but there's also a lot of actions that can be taken, especially by those working closest to them, like the health professionals, that can actually address these issues. Sarah, I leave it over to you now.
Thank you, Marie-Noelle. I'm really appreciative of this presentation and of the two preceding presentations. I feel like this marketplace session could have easily been 2 hours to allow for rich dialogue. Really, all of you presented very compelling and really important concerns and how you are responding to those concerns. So I'm honored to be here with you today and to learn from all of you. So thank you very, very much. I'd like to invite all of you to continue with the next sessions for the conference. You can go from here to the session on for the awards. The Community Health Award and the Dory Storm Award are being given today. And immediately following that, there'll be the final plenary, which also promises to be thought-provoking and a great way to wrap up our conference. So please, everyone, join me in thanking all of our panelists today on the Child Health Marketplace session. Really, my personal thanks to all of you, and I wish you all a great continuation of the Core Group Conference.